In the following video, we are going to show you how to ace your EMT medical assessment. Let's begin by going over the general scene size-up. So we begin with PPE. The purpose is to protect yourself from bloodborne pathogens and airborne illness. Say or do, I'm putting on gloves. If there's a potential for fluid, say I'm also using eye protection and a mask. Always do this before you approach the patient. The examiner will look for it, and if you fail to, you will fail your exam. Now, while we're observing the situation, we need to ensure scene safety, so ensure no hazards will harm you. Say, I am evaluating the scene for safety. If there are no hazards, you can enter. If hazards are present, wait until police or fire clear them. Never assume safety, and you must state you are checking for it in your exam. Now we have to determine the mechanism of injury or nature of illness. So this is helping to guide your primary assessment and transport decision. Say, for trauma, this appears to be a fall from blank height, possible blunt trauma. For medical, the patient is experiencing chest pain, likely cardiac in nature. So that's the nature of illness for medical. A tip is to tie in what you observe with potential injuries. If you see a broken windshield, a potential head injury. Now determine the number of patients to know if you need more resources. Say I see 1, 2, or however many patients you have. Always do a good scan of the C before declaring this. Your instructor may try to trick you by hiding other patients. Make sure you get this correct. Now we are going to request additional help if needed. So pretty much every exam you are going to request ALS. So you can say I am calling for ALS backup due to whatever injury, due to chest pain, due to cardiac involvement, due to head trauma, anything, but always request ALS during your exam. Now we are going to consider spinal stabilization. This is to prevent further spinal cord injury. So say I'm considering spinal motion restriction based on the mechanism of injury. I will have my partner manually stabilize it, but you do not need to use a C-collar at this time. If there is any injury that the spine could be potentially injured, use spinal immobilization to prevent further injury. Now that we finished the scene size up, let's jump into the primary survey. Now we are going to jump into the general impression. So describe what you observe. The patient appears to be middle-aged, whatever, but comment on their age, sex, level of distress, position, surroundings, and any obvious trauma that you visually can see. This is to describe what you observe immediately. Now we're going to determine the responsiveness level of conscious level. So quickly gauge the brain function by using AVPU, alert, verbal, painful, unresponsive. Say I'm checking responsiveness using AVPU. A, you can say, can you tell me your name? V, you can say, can you hear me? P, you can apply a painful stimulus such as a trap pinch. If no reaction, the patient is unresponsive. For medical calls, you can also check orientation by asking questions like, what is your name? Now we can determine the chief complaint. So we find out the main issue from the patient or bystanders and look for anything that may kill them immediately. Say the chief complaint is chest pain, or he's unconscious and not breathing, immediate life threat. Look for difficulty breathing, uncontrolled bleeding, altered level of consciousness, or signs of shock. We can then assess the airway and breathing. So this is to check for patency and breathing effectiveness. Say and do. I'm assessing the airway. It is open, clear, and patent. Or the airway may be obstructed and you have to perform a head tilt chin lift or a jaw thrust if spinal injuries to open the airway. Check the breathing rate, rhythm, and quality. Then we can assure adequate ventilation, so we can make sure the patient is moving enough air. Say and do. Breathing is inadequate. I'm assisting ventilations with a BVM at 15 liters per minute. If the breathing is adequate, you can state the rate with good chest rise and explain to your instructor that you do not need a BVM. Now we can initiate oxygen therapy, so deliver oxygen if needed, either using a non-rebreather at 15 liters per minute or a nasal cannula at 2 to 6 liters per minute, or oxygen may not be indicated. But most likely in your exam, administering oxygen will not hurt, and BVMs are often used unless the patient cannot tolerate it and needs a nasal cannula instead. After that, we can assess circulation by looking for life-threatening hemorrhages, which need an immediate intervention. Say I'm checking for major bleeding and control it immediately with direct pressure and a tourniquet. Do a quick head-to-toe scan if trauma is suspected. When bleeding is controlled, we can assess the skin. Look for the color, the temperature, and the wetness. So you can say the skin is pink, warm, and dry, or pale, cool, and clammy, which can indicate different conditions and different injuries. Say at least two of the three: color, temperature, or condition. Now we can assess the pulse, so determine the perfusion status. Say I'm checking the carotid radial pulse and state whether it is regular or abnormal. If there's no pulse, initiate immediate CPR. Do not wait. Check the carotid for unresponsive and shock patients and the radial for alert ones, as the carotid can look like you're choking an alert patient. Do not hesitate for life-saving interventions. Now identify priority patients and make the transport decision. If it's triage, you have to sort out which patients are which, and if not, decide if rapid transport is needed. In your assessment, use rapid transport. So you can say, due to chest pain, this is a high priority patient, I'm requesting immediate transport, or the patient is stable and continue on scene. Do not do that. Use rapid transport in your exam. We are now finished with the primary survey. Let's jump into the secondary assessment. We will begin with finding the history using OPQRST. So the O is onset. You can say, when did this start? P, provocation. Does anything make it better or worse? Q, quality. Can you describe the pain? Is it sharp, dull, crushing? R, radiation. Does the pain go anywhere else? S, severity. On a scale from 0 to 10, how bad is it? T, time. Has it been constant or does it come and go? Clarifying questions, you have to ask follow-ups related to the symptoms. An example, have you had this type of chest pain before? Do you feel short of breath or lightheaded? Now you have to find the past medical history using SAMPLE. So S is signs and symptoms, which is already covered in the OPQRST. A is allergies. Are you allergic to any medications, food, or environmental factors? M, medication. Are you taking any prescriptions or over-the-counter medication? P, past medical history. Do you have any medical problems or chronic conditions? L, last oral intake. When did you last eat or drink anything? E, events leading to illness. What were you doing when this happened? And clearly document or repeat these back to show you've processed them. We can then perform the secondary assessment, which will help identify signs and symptoms related to the specific body system. So do a focused physical exam based on the chief complaint. An example would be for chest pain. Listen to lung sounds, inspect the chest wall, and palpate for tenderness. You're trying to find what is the issue. Is it a heart attack? Is it a pulmonary issue? If pulmonary issue, you can listen to their respirations, lung sounds, and look at how their muscles are moving when they're breathing. Other things could be musculoskeletal, integumentary, reproductive, or you can say, I'm assessing the blank for abnormalities. If time critical, perform a rapid head-to-toe due to unstable presentation. Now we're going to assess the vital signs. So assess the hemodynamic and respiratory status. State or obtain. The radial pulse is 98, regular and strong, or whatever the pulse is. Respirations are blank, normal, unlabored, labored, anything. Blood pressure. And you can also use the AVPU, so the patient is alert response to verbal, etc. Now we're going to check diagnostics. You must include an ECG for chest pain or shortness of breath. This is a pass or fail. Say, due to chest pain, I'm applying the cardiac monitor now, or I'm monitoring SpO2 and capnography if available. Here you can state your field impression of the patient. So summarize your diagnosis. Example, the patient is a 60-year-old male with likely cardiac-related chest pain. Possible hypoglycemia based on altered mental status and history of diabetes. Be confident even if you're not 100% sure. After your field impression, you can verbalize your treatment plan, showing that you know how to manage the condition. You can say, example, I will administer aspirin and assist with the patient's nitroglycerin, or I'll give high-flow oxygen and prepare for rapid transport, etc., etc. Include ALS backup if needed. Finally, we can reevaluate our transport decision, so confirm whether your patient needs urgent transport. In your exam, your patient will 99% need urgent transport and require it. Say this is a high priority transport due to whatever condition the patient has. Now that we have finished the secondary assessment, we can reassess the patient. We'll begin by repeating the primary assessment. So check for new airway obstructions, worsening breathing, or changes in consciousness. An example is, say, airway is still clear, breathing remains adequate, patient is alert and oriented. We are now going to recheck vital signs. So reassess blood pressure, pulse, and respiratory rate, or anything else such as glucose. Compare it to the previous readings to detect trends for medication, or you can find injuries such as drop in blood pressure and rising pulse leading to shock. After that, you are going to reevaluate your interventions. So check oxygen delivery, reassess the effectiveness of medication, ensure bleeding is still controlled by bandages or tourniquets, etc. Finally, you are going to recheck the chief complaint. You can ask the patient, how is your pain now? Is it better, worse, or the same? Is the shortness of breath improving with oxygen, etc.? Here I've attached critical fails that if you hit any of these, you fail your whole assessment. Please look at these, write them down, or take a picture to make sure you avoid all of them. Thank you for watching. Good luck.